Well, good morning, everyone, and welcome to the public board of Lincoln Community Healthcare Trust. You're all very welcome, whether you're watching us live or whether you're watching a repeat catch-up on this via your favourite catch-up service. The board meeting today is our normal public board, so I'm going to move straight into my part of that, which is just to welcome you. To make a few brief opening remarks, you'll be grateful for that. It's been quite a momentous week already in terms of the health economy. We have a new health minister, which we very warmly welcome, Lincolnshire MP. So that'll be very interesting for us to adjust to that. I'm also aware that the system is very much under a lot of pressure at the moment. And one of the things that we need to do as the Community Trust is to be really clear as we go through our deliberations today, that we answer that question, how we can help those frontline services, whether they're our services or whether they're services in our partner organisations like the Acute Trust. So there's a lot responsibility on us today. It's also Self-Care Week, which I think for a community trust is a particularly relevant one, as we support those members of our community to manage themselves and to take care of their own health going forward. I couldn't go forward today without mentioning that we had our awards ceremony for the trust last Friday. That I found an absolutely fantastic event. I hope those of you who were able to attend really enjoyed it. And for me, the highlight is seeing our frontline staff return to a venue to come forward for awards, to enjoy themselves, to tell us their stories. I enjoy talking to people, and it really reminds you of why we're here and what we do as a trust. Okay, let's move on from those brief remarks. Public questions. I don't believe we have any public questions today. No, that's great. Thank you very much. Any apologies for absence that we need to record? Otherwise, from that, I think we've already recorded one non-executive director's, Jim Connolly's absence. Any more? Don't think so. Nobody's indicating to me. Okay, so I will invite anyone to declare any additional declarations of interest in addition to those already in the register. Anybody got anything additional they want to add today? Again, gosh, we're moving forward quickly. Catherine, you put your hand up.
Hi, Chair. Just to note, there is one addition that we need to add for Professor Dunderdale in terms of the Deputy Chief Executive post across the group. Thank you.
Great, thank you, Catherine. Okay, so then I'll turn to the minutes of the previous public board meeting on the 23rd of September. It's not my normal way to go through these page by page, so I invite anyone to indicate whether they have any comments, additions, corrections that haven't been previously notified. I look around my screen, I don't see any of those. That's very good. And then we have the decision log, which from that meeting that only has one item on it that's complete, so I don't think we need to linger on that either. Crikey, I'm going to finish before 9:30 at this rate. Okay, so the next item is item 1F, which is to look at the forthcoming board programme. Do you have any comments on this, Catherine?
Thank you, Chair. Just a couple of updates further to some conversations. So the 7th of December Quality and Risk Committee development session will be stepped down. There will be a different session taking place in December, and the 12th of December Group Model Trust Board session will be stepped down as well due to annual leave of board members across the group. Thank you.
Okay, great. Thank you for that. And then this brings us to a really important part of our regular board meetings, which is a patient story, where we try and get information on stories really that should be good and bad in terms of experiences of our services, because for the board it helps us stay rooted in what's actually happening on the front line. I know we're being joined by Leo Whiteman for this, but is an executive director introducing this? Anne Louise, is it? Okay, over to you, Anne Louise.
Thank you, Malcolm. I'm absolutely delighted to introduce Leo Whiteman to everybody. So this is actually a patient and a staff story combined into one, because this is much about Leo for me as the patient that he helped. Leo is our head of medical devices, and continue singing his praises. He's the only community trust lead healthcare scientist in the region. So without any further delay, I'm going to hand over to Leo to tell us about his journey. And Brian, thank you so much for joining us, Leo.
Thank you, Anne Louise. Right, I will share my screen with you. Oh, did it jump to the end? No, okay, there we go. Okay. Right, so yes, I'm here today, in all honesty, to raise awareness about the work that healthcare scientists can play in healthcare innovation. However, rather than give a dry account of what healthcare scientists are and what they can do, I thought it would be much more powerful for me to tell you the story about Brian Moss, a patient I worked with when I was a trainee. The impact the work had, not only on him, but on me too, and then later for so many others, as ultimately the work I did with Brian set me off on a path to develop eye gaze technology to the point where now LCHS's very own EATS team are the ones setting out the best practice for eye gaze assessments and setting the example for other national services to follow. Okay, so before I speak about Brian, I want to speak a bit about who I am, how I came to be a healthcare scientist. So originally I did a master's in mechanical engineering, specialising in ultrasonics. I then enrolled on the National School of Healthcare Sciences Scientist Training Programme for clinical engineering, wasting another 3 years of my life doing another master's, this time in clinical sciences, specialising in rehab engineering. So as part of this training programme, I did work-based competencies in medical device management, clinical measurement and ICT, design and development and rehabilitation engineering, which I ultimately specialised in, as I say, which consisted of clinical gait analysis, assistive technology, and engineering design. Of those, I ultimately super specialised in electronic assistive technology. So that's environmental controls, alternative and augmented communication, and access to computer technology. And I'm speaking to you today. My current role is Head of Medical Devices and Assistive Technology and Lead Healthcare Scientist for LCHS. Okay, so Brian. When I met Brian, I was still a trainee and I'd never met anyone with motor neuron disease before. Of course, it just so happened that on the day I met Brian, I had 4 other visits, all of which were for people with motor neuron disease. The day had been very upsetting and difficult for me, and when we pulled up outside Brian's family home in the car, I almost couldn't bring myself to undo my seatbelt, get out of the car, go into another person's home and see it all again. Brian was at a fairly advanced stage in the progression of his condition, a lot further along than the other patients I had seen that day. He had no functional upper limb movement left in his body, and his speech was severely dysarthric, slurred, to the point where he was unable to communicate verbally in discussions. However, despite these barriers to participation in the conversations, it amazed me the way that his personality and warmth shone through, just through the smiles, facial gestures and laughter alone. It was to the point where I was distracted from the day I had just had, and indeed from Brian's own upsetting situation, by quite how much I was enjoying his company. At the time, there was no specialised communication aid service in place. The service I was with was for environmental controls only and used external contractors for all equipment installations. Through a discussion, we identified that Brian really wanted to do was use his computer to have a means of communicating face-to-face with his family. But the external contractor that the service I was with was using didn't provide such things. So as such, he was going to be provided with a system to change the channels on his TV, and that was going to be it. That seemed desperately wrong to me. Surely there was a way we could help. I really liked Brian. I wanted to help him any way I could, and he certainly deserved better. Brian's son, Stuart, just happened to be the head of innovation and IT at Rolls-Royce, and he shared this same belief with me. And essentially, he and we went off together, did some digging, and eventually came across eye gaze technology. And at the time, this technology was nowhere near as prevalent as it is now, and information was scarce beyond, the stuff that the manufacturers were plastering across their websites. But eventually, through Stuart's contacts in America, we were able to source an eye gaze camera for Brian, and Stuart and I worked together to get Brian fully kitted out with a comprehensive electronic assistive technology system, enabling him to communicate both face-to-face and using text messages, and to control devices in his home environment. All of this done through Brian's eye movement alone. The last interaction I ever had with him was when he used his eye gaze to say thank you to me. Brian then died on Christmas Day in 2014. So I've got a video now of Stuart, Brian's son Stuart, speaking about the impact that the eye gaze had on Brian. Okay, I should just say, so that's edited down from a 90-minute conversation I had with Stuart. And actually, Stuart just told a story there about how, unfortunately, Brian was assaulted, and he used his eye gaze system to be able to report the assault to the police, and it resulted in a conviction and the person losing their job. So that's why he speaks about using it to defend yourself. Okay. Ooh. Do that maybe. There we go. Okay. So what happened next after Brian? So as I say, I found the state of eye gaze provision in the UK to be completely intolerable. And really the big benefit for eye gaze is in using it to communicate, and that is where it's most widely applied. And as I say, I was working in the Environmental Control Service. Lincoln Eats were the communication aid service covering the East Midlands. So that's ultimately why I ended up coming to LCHS to join Eats. Once I was in post, I set to work researching eye gaze technology to make it no longer a black box. No one in the country seemed to really know about how it worked. And there was a lot of trial and error in assessments, and I was believing that we were seeing poor outcomes as a result of that. So I wrote a 30-page document on how eye gaze works, and it's got all these diagrams, equations, and graphs and stuff in there. And one of the bits of feedback I had in this slide was that it looks a bit, what's the point in that? It's very small, you can't really see anything. And I think actually it kind of makes the point perfectly. I made a 30-page document and all this technical stuff, and I wondered why no one was listening to it. But then thankfully, through LCHS, I did the LDP, and I think actually that was something that enabled me to kind of see the wrong in my ways. And actually, I distilled all of that information down into a much more accessible training package. And that training package initially I rolled out to, I started off just meaning for it to upskill the other eye gaze assessors in LCHS, but actually ultimately it has become something that I've gone around the whole country, training all the other services on how to conduct a more methodical eye gaze assessment. And I think it's, you know, one of my proudest bits of work is, it used to be that in the EATS team, it was, if there was a complex patient, send Leo because he's the one who knows about eye gaze. And it was, oh, Leo knows that. But I believe I empowered the people in the team to know this for themselves. And whenever I go into like some patient notes and I see them using the language that that I've taught them about eye gaze, it makes me feel very proud indeed. And like I say, I believe we're seeing much better outcomes with the application of eye gaze technology now. And Lincoln is leading on this. I'm modest about a lot of things, but I will say that I think if you are being seen by Lincoln EATS, you are having the best eye gaze assessments in the country. Okay, I've continued to collaborate with Brian's son, Stuart. So there we are here appearing in the paper in Derby. Down here, you've got me. That's actually Brian's grandson, Max, coming in to give some eye gaze cameras that they donated. And here you've got me next to Stuart. So Stuart and I, we're part of what's called the Next Generation Think Tank, which is a collaboration between companies such as Rolls-Royce, Google, Microsoft, Intel, Dell, and LCHS. We're there too. So we're working on the next generation of technology for people living with motor neuron disease. It's had all sorts have come out of this group. People might be aware of the voice banking service, I Will Always Be Me. For me personally, I initiated a research project with Google and Intel on using a neural network to diagnose MND through MRI scans, a research project that never got off the ground because ultimately when we took it to clinicians, they said, no, actually the diagnosis is something that it's just a matter of being seen by the right person that makes it complicated. So yes, but we've also got patients as a result of this collaboration who are on, they're on the cutting edge. I've got 2 patients who are enrolled on trials on the product called Google Project Relate, which is voice recognition for people with non-standard speech. So yes, we're getting all of this innovation going on, and we're working with these sorts of companies, which I think is fantastic. The Next Generation Think Tank has been very well recognised. You've got me here meeting Princess Anne at a celebration event for the research group. It looks like I'm telling her off. I didn't realise you meant to. I went against her on something which I didn't really realise was something you're not supposed to do, but that lady seems to be thinking, oh, that's a bit interesting. Okay, so what now? I mentioned earlier that the last thing Brian ever said to me was thank you. I would just like to use this public board as an opportunity to, you know, it occurs to me that actually so much of what I do was set off from Brian. So actually, thank you, Brian, for everything that you've done for me as well. However, those challenges that I faced with Brian, they weren't isolated to that point in time. We're still facing them now. With the NHS long-term plan, adopting technology introducing it to service safely and effectively and delivering better care closer to home, we need to be making sure that we're adopting these cutting-edge technologies and putting them into practice safely and effectively. I've got a quote there from Stuart from that big call we had. So he said, if you work with people who look like you and sound like you will always get the same result. So what am I calling for there? I'm calling for more involvement of healthcare scientists in our services, in LCHS, in the community, where actually I think the most dynamic changes are there to happen. So yes, so I'm here to say that healthcare scientists are here, and we have a vital role to play in delivering on the strategic objectives of LCHS and indeed the NHS long-term plan. Okay, that is everything from my presentation. Any questions at all?
And Louise, you put your hand up first.
Thank you, Margaret, and thank you, Leo. I just want to come in, first of all, thank you for such a powerful story, and it reminds me that whilst what we do is try, our core business to try and help the people that we serve, that the people we serve can have a profound, life-changing impact on us as NHS staff. And we could, I can remember patients I cared for 30 years ago, and they stay with you and can profoundly change the course of your career. So thank you for sharing that emotional story. And I think there are some clear messages celebrating the diversity of our workforce, what the role healthcare scientists can bring to enhancing patient care and thinking about how we support people in a different way. And finally, really wonderful to hear that the LDP helped you successfully deliver what is a nationally recognised programme of work. So just thank you, Leo. Thank you, Chair.
Thank you, Anne-Louise. Sam.
Yeah, thanks, Leo. Great work. I just wanted to ask what sort of numbers of people we're now supporting with eye gaze technology, and also sort of from a financial perspective, how quickly have we seen the costs of new tech start to come down as we roll out and scale up?
So in terms of the numbers, eye gaze is no longer something that we, if anything, I believe that one of the things that my training package addresses is the fact that there is a bit of a bias in many EAT assessments of, because eye gaze is so fantastic, it is so fast and direct, that quite often people go in with, okay, try eye gaze, does it work or not? If not, move on. But actually, I believe there's a bit of a confirmation bias that can creep in as a result of that. And so we quite often get people who are provided with eye gaze when it isn't actually the best thing for them. So having said that, yeah, eye gaze isn't something that's occasionally prescribed, if anything, it's overprescribed. And I believe, so that each service, I would say it's probably close to about 500 to 700 users that we've got out there. Sorry, that's quite a big margin of error there, but yeah, it's about that ballpark. So and your other question around, has the price of the technology come down? It has, certainly, and where it was before is it used to be you would buy your eye gaze camera and it'd be integrated as part of an overall system, and that was a very expensive system. So the way the prices come down is through two means. Number one is the fact that you now can buy modular eye gaze cameras on their own in isolation, and that makes them more accessible. And the second thing is that eye gaze is broken into the gaming world, which has meant that actually all of a sudden there's a lot more interest and development going into it. And you can buy a £100 eye gaze camera off Amazon. This isn't the good news story that you'd hope it would be, though, because the people that make the £100 eye gaze camera on Amazon also make one for the disability sector. And they got it so that if you plug in one of their gaming ones into a communication aid, it recognizes it and it stops it working. But we are seeing a reduction in costs, though, nonetheless. It's not all terrible news.
Thanks for that question, Sam. Andrew.
Yeah, thanks, Chair. Morning, Lee. I'm not sure if we've met or not. I'm Andrew, the Group Chief Exec. Really enjoyed your presentation, and I know you said thank you to Brian at the end. Yeah, thank you from me to you for the great work that you are doing. And I was particularly interested in your comment about the greater involvement of healthcare scientists, which I would certainly applaud. I do think many people just think of doctors and nurses when they think of the NHS, and I do think now we are a group, and the other bit of the group, the ULHT bit, also has healthcare scientists. I would hope we can use that as some way of allowing our scientists to sort of huddle together for warmth, so that you have other like-minded people to speak to, but then how we maximize that collective effort to do the sorts of things that we want to do. So my sort of takeaway message is to get my head around how we do that, so that you and all our other great healthcare scientists really can have the sort of impact that we saw in the presentation, but have that impact on far more people across the system and across the group. So thank you for making that point. And I've also made myself a note to, now I'm back at LCHS, to come back out to see you and your colleagues. I went out many times when I was here last time, saw the great work you do, and it'd be great to see how you've moved that on in the 4 years that I've been missing in action, as it were. So look forward to seeing you and your colleagues shortly. But as I say, thank you for the great work, and thank you for the presentation.
Thank you.
Thanks, Chair.
Thanks, Andrew. Julie.
Hi, Leo. I wanted to say thank you, but for being quite inspirational. You didn't sit in your car, and I think that you've left that with me. So thank you. Also, as your Chief Operating Officer, I wanted to know if there was anything I could do to help all the rest of us. Probably not to answer now, but I think what you've left us with, I need to make sure that we're leaving you with the help and leverage that would make even more impact on the patients that you serve. But thank you for being you.
Well, thank you, Julie. I will just, you said not to answer now, but I do have just one thing that I'll say, and I'll actually come back to something that Andrew said earlier. He spoke about healthcare scientists at ULHT and us all, I think you said, huddling together for comfort. No, we all need to be taken out of our comfort zones. I think, you know, that whole story I've just told then was about me breaking outside of my own comfort zone, and I think that's what they need to do. Sorry, that's like I'm doing. Yeah, they need to. You know. So I have got, as part of the work that we're doing, the medical directorate, I have put something in line with the strategic objectives to get healthcare scientists. I'm going to say it again, Anne Louise, bolster the role that they play. So I always say the word bolster, and I'd say that my initial suggestion is just to map out what we have across the system and then think about, okay, how can that translate across to LCHS? Okay.
Right. Thanks, Leo. You're allowed to push back. We are, you know, we encourage it at this board, so don't worry about that. Gail.
Yeah, thank you, Leo. Yeah, again, a massively inspirational story. I just would have loved to have met Brian, so you left me with that thought. I'm following up on something that Julie, I think, started on, and I know she said you can come back to us, and you said you can answer some of it now. But I'm trying to find out what tangibly you said. I'm calling for more involvement of NHS services, EAT services in the community. I just wonder if you just tell me a bit more about what that looks like for you, so that, because as a board, if we're going to help make that happen, what does it look like to you?
So I think you've got a prime example in the work that's going through at the moment with point of care testing. I think it is about, you know, so you've got this new technology that's available. Well, sorry, point of care testing is not that new, but, you know, nonetheless, it will be new in the way that we're looking to apply it. And actually, ultimately, it is a risk that you're talking about taking on when you adopt a new technology, and especially if it's a deviation away from. So in the context of point of care testing, it's as opposed to sending someone off to have blood tests from a lab, which is your gold standard. But actually, okay, is that always actually the best thing? There is a risk benefit analysis to be done. So as such, I would say it's about involving healthcare scientists, because they are like the specialists in in evaluating technology through parameters of specificity and stuff like that. So actually adopting new technology safely and effectively, I think it's something that they can provide valuable expertise on that, so that it's not just, oh, this exists, let's adopt it. It is, as I say, it's doing things safely and effectively to progress and advance care. By having more immediate care out in the community, because I think if your model is no, in order to have the best thing, you have to go into the hospital because that's where the complex equipment is. No, we need to be getting out into patients in the community, and that means adopting new technology, and that means the involvement of healthcare scientists.
Perfect, thank you. I've got
Great.
it. Yeah, no, that's helpful. Thank you.
Great question, Gail, and great response, Leo. I'll keep this going. It's so interesting. Karen.
Yeah, thank you, Leo. I'm usually one of the first to put my hand up at such sessions on the board agenda, but actually I took some time because I was so taken aback and taken in by the story and your role, Leo. I'm the professional lead for allied health professionals and healthcare scientists. So absolutely understand when we often think about other professions associated with healthcare, as somebody's already said, we think about doctors and nurses. And then when we break that down a little bit further, we think physios, OT and SALT. But actually there's a whole range of others, healthcare professionals that support prevention, diagnosis and treatment of many, many medical conditions using their expertise. And I think you've described that perfectly this morning with your story, but also Brian's story. And I was just taken by the fact that, we often hear about patient stories and we see a real demonstration of how that's impacted on the healthcare professional and changed the way that they practice, think, etc. And you can really see that with you. And I think, most of us have got experience of that. But the additional thing was that you also were able to describe the leadership program that you undertook, where the organisation also changed the way that the direction and the journey that you were on. And when the two things collided together, Brian's story and your own professional development, look what happened. I mean, it's just been fantastic listening to it. And I'm really in awe of what you've tried to do and how you've actually flexed, moved. You've been really flexible, you've been really innovative, and you've been, and your thinking has been really innovative as well. So just a huge thank you from me. First of all, coming and talking us through all of this and allowing us to experience some of your journey. It's a real privilege, Leo. So thank you.
Thank you, Karen.
Murray.
Thanks, Chair. Thank you, Leo. At heart, I'm not a clinician and I'm not a scientist, so forgive me for using very, very human, normal language in some of this space, but it strikes me that one of the real benefits of bringing the group together is this risk benefit from the patient's point of view to moving service from a very traditional, you need to go to a big building somewhere that for many of our residents requires a significant amount of travel to be able to receive the gold standard service. And I would really welcome a conversation, which we've had in previous places in a number of times, about how we expand some of the digitally enabled pathways to actually allow that, what from a patient's point of view is actually an equality issue, to be able to access that high level service where you live or as close to where you live as possible, whether that's then reporting through and being clinically oversight by a primary care practitioner, an allied health practitioner at county base, or indeed a highly skilled clinician in one of our hospitals. And I, as a an ops director by background, and still can't get away from when are we going to do it type questions, I would really welcome the board moving into a space of if we are really going to, what was the phrase I heard the other day, spread acuteness. This is a tool, isn't it? We're working with scientists, working with our digital colleagues, and actually working with providers in the care space who very often are using monitoring equipment, which edges into some of this, and the crossover must be there, is widely rolled out. So it strikes me that this is an area that really, as a group, we should be spending a little bit of time thinking through as one of our strategic answers to the questions of good quality healthcare, but also equality of access to healthcare.
Yeah, Murray, I'd just add to that. I think LCHS has got a really good opportunity with the EATS service, because the work that EATS does, it is on the edge of health and social care, for us to look at what's working there and can that be used as a blueprint and carried out across the integrated care system, and then actually will that blueprint be useful to other integrated care systems across the country, because like I say, we have got this really good opportunity, and also with our patients in Lincoln standing to benefit perhaps the most with just how enormous the patch is.
Thanks, Leo. Andrew.
Yeah, I mean, thanks, Chad. I think Murray's probably said what I was going to say. That this feels like a real example where we can push the boundaries of the home first or great care close to home agenda, but probably more importantly, make it real and really make the point that, normality for people is being at home or close to it. Normality is not spending lots of time going to hospitals or being in hospitals. Well, wonderful though hospitals can be for some people, for this topic, it really does feel like we should max out on what is the art of the possible in people's own homes. So really good to hear Murray's comment, really good to hear Leo's response to that. There's a challenge to us then, isn't it, of getting on with it and doing something positive, practical and impactful in as close to real time as we can actually do it. So yeah, great point. Thank you very much.
Thanks, Andrew. I'll try and wind up. I mean, I found Brian's story astonishing and positive and moving. So thank you for that, Leo. And I know it's your story as well. And you could see, I think, from the reaction of the board that they're activated on this and can see the value both in the microcosm of what you've done for Brian, but also what that's brought to a wider group of patients. And I said in response to one of the things you said earlier that we need to be challenging, and I think Murray was, and I think I'm looking to Karen and to Andrew to think about how we do create the right space, because I've sat, I mean, I'm way too old, and I've sat at multiple tables where people have sat and talked about how do we foster innovation. And your story is a classic one where the people at those tables originally probably weren't even aware it was going on. So actually creating the culture for innovation and then supporting it and finding ways to bolster it, to pick up your word there, Leo, I think is the challenge for us. And it's a very real challenge. And I'm really pleased, Murray, that you put it in the context of the group, because we're looking for those great opportunities that we've got as a slightly larger group of organisations coming together. And it strikes me, and again, back to Karen and Andrew, to think about how we take this forward, that we need to think actively about how we create not I don't mean the bureaucracy of programs and oversight. I mean the culture and space in which we encourage people to go out and say, look, we can do good things here. Well, that's a good one. Let's back it, and allow that innovation and that trial and that ability to say, well, this will work, maybe this won't, but actually until you try, it won't. So you've triggered some fantastic thoughts and discussions today, Leo. So thank you for joining us. Is there anything you'd like to say finally in conclusion?
No, only just to say thank you all for your very kind words, and I'm very pleased that it's resonated and you've all responded to it in the way that you have. And yes, and thank you again.
Thank you. Well, we've clearly created some environment and culture where you can prosper. We need to work on building it up to extend. So thank you very much for joining us today, Leo. Absolutely fantastic story from you, and Brian's story as well. So thank you.
Yeah, thank you.
Thanks, Leo.
Bye for now. Bye.
Well, I'm almost inclined to say follow that. So, but luckily I can say that because I can turn to the group CEO and say, it's time for your report, Andrew. I feel I need to sit down in a darkened room for a little while, but let's press on. Andrew, let's move to item 1H, and that's your report. Thank you.
Thank you, Chair. My reports normally make people want to sit down in a darkened room, so thank you for leading me in to that one. So usual format of a bit about the system, a bit about the trust, and as ever, the minute you write these reports, they slightly either are out of date or life takes over. So in your introduction, Chair, you mentioned the new Secretary of State, so Victoria Atkins, the MP for Louth and Horncastle, and on our collective behalf, I did send a note to the new Secretary of State last night, to congratulate her on her appointment, but also to offer any discussion she might like about healthcare in Lincolnshire, but also the opportunity to come and see our services in operation if she wanted a sort of early opportunity to be out there as the new Health Secretary visiting services. So if you suddenly find the Secretary of State with us, that's my fault. But I thought it was the right thing to do. So what I've tried to pick up in this report, clearly, as we know, services are under pressure, haven't got any industrial action planned at the moment, but there is a ballot due fairly soon, so that may result in more industrial action. But the comment I made a moment ago about the Secretary of State may engender a new relationship, new talks, or whatever. We will have to see. Whilst all of those pressures being coped with, obviously nature has taken its course on us. So we've had various storms, and just wanted to thank all of our people for the great work that they did during a couple of storms ago now, Storm Babette, keeping our patients safe, supporting colleagues, and just as ever going above and beyond to keep the services going and to keep everyone safe. So I thought it would be remiss of me if I didn't mention that as I had the floor. In terms of other things that have changed since this report was written, I've mentioned here where we are on urgent and emergency care. Lots of focus at the minute on ambulance handovers, which isn't just a matter for the acute part of the group, very much a matter for us around attendance avoidance, admission avoidance, discharges, the whole pathway around urgent and emergency care, but a real spotlight at the moment on making sure that risk is not placed on patients around ambulance handovers, that it's placed in the right part of the health system, and that between us, we enable ambulances to be out there visiting patients, collecting patients if needed, and conveying them where necessary. So huge amount of work at the minute on that topic. And on the money, since this was written, and I've listed there where we are as a system on the financial position, and I've listed where we are on the financial recovery plan. We should hear after today whether the system has exited the recovery support programme. But on the financial challenges that the NHS faces, particularly those created by industrial action, since I wrote this report, we have had communications from NHS England about addressing the financial challenges created by industrial action, and refocusing the efforts of the NHS on financial balance, protecting safety, prioritising urgent and emergency care, and protecting the high priority elective work. So that will tend to be the long waiters and cancer cases. So there are revised plans needing to be submitted by the 22nd of November to address those priorities. So a huge amount of work on the go at the moment across the health system to provide the revised plans. And in financial terms, that will be about the system coming in at year end on the £15.4 million deficit that the system said it would hit when plans were first submitted. There were already risks around that plan. The one we've got to submit by the 22nd has to show how we will hit that 15.4 million and how we will protect and deliver urgent care and how we will protect and deliver the high priority planned and elective care. So lots of work, Chair, on the go on all of that. The other bits I just mentioned here, despite all of those challenges that the system has had, the QSRM meeting, so the quarterly system review meeting, was a positive meeting. We have considerable support from NHS England in the Midlands. They know that we are all over the topics that create those challenges. They have considerable confidence and faith in the Lincolnshire system. So overall, trying to summarise 2 hours of work, 2 hours of discussion, I would say it was a positive meeting, a positive discussion, but clear expectations that those issues where we need to make progress, that we do that quickly. One of the issues that was discussed briefly was the new urgent treatment centre that's now opened at Grantham Hospital to replace the reduced hours A&E. And we also talked about the group, albeit at fairly high level. And I've made the mention here that the chair process, local chair process concluded last week. Final sign-off is a national decision, and unlikely that we will know that before the middle of December. In terms of the trust-specific issues, a bit of an award special, I suppose, this report. So I've made mention there of the apprenticeship awards, the fantastic Celebrating Success event that a number of us were at on Friday evening. The great news that Lauren O'Meara received the first Healthcare Support Worker Award from the Chief Nursing Officer, so the first that Lincolnshire has received. And again, for Karen and I, it was a delight to be at that event, to see Lauren and to be present when she received that award. And also the award here from for our selective mutism team, again at the National Royal College Speech and Language Therapy Awards. So great work going on across the trust. And we just heard from Leo, didn't we, about the other great work that he's been doing. And I think if you look at the strategy for our health system, whether it's the integrated care partnership strategy, the joint health and wellbeing strategy, or the joint forward plan, all of the work LCHS is doing is absolutely central to those strategies. So it's both great to hear about the work, great to receive the awards, but also, really essential that we keep the pace and the impact on that work, so that we can play the absolutely central and pivotal role that the health system needs us to provide. So at that point, Chair, I will stop. I have also attached the feature focus there about our holistic health work, where we obviously look after our people, look at them in the round, look at mental health, menopause, financial support, just in effect try to be a great employer interested in our workforce and making as much support available as possible. So I hope people enjoyed reading that feature focus. Thank you very much. I'll stop at that point.
Great, thank you, Andrew. As I said at the start, there's an awful lot going on at the moment, and it's great to celebrate stuff, but it's also great to think what more can we do in the group and the system structures to try and make sure Lincolnshire gets through the winter best it can in terms of its services to the public of Lincolnshire. Gail, you have a comment or question?
Yeah, it's a comment. Unfortunately, Malcolm, I've got to dip out at about 11 just for a short time. So I wanted to ask this question. It was more a comment, really, Andrew. That and this is with my wellbeing guardian hat on for the board. So the feature focus I thought was fantastic, and it's a really nice short form way of getting a lot of information across. And so I was just going to say, as colleagues around the board, can you print this off and keep it with you so that when you're out there and you're talking to our staff, etc., etc., it's a really good way of being aware of what's going on, etc., etc., and raising that awareness. So it was just a request for all board colleagues to make themselves really familiar with that. That's all. So thank you, Malcolm.
Thanks, Gail, for those comments. And I know you're also presenting the next item 2A, so I'll hold that over till you're back the quality review. So
is that okay? Thanks, Malcolm.
No, that's fine. So that's
doing the quality committee report. Yeah, that's right.
Yeah,
thank you.
So that's just a heads up to whoever's presenting 2B that we'll be coming to you after this. Okay, Ian.
Yeah, thanks, Chair. Thanks for the report, Andrew. I thought it was very helpful. I just wanted to pick up the exit from the recovery support programme issue. When I read the report, I thought, well, it sounds as if there's some room for optimism there, given it's been through NHS Midlands and then has gone nationally. But then you've updated us on the more recent information that's crossed your desk, and you talk about a submission, I think you said on the 22nd of November. I just wondered, are the two connected in that sense? Does it put a threat under the meeting today, as it were?
Yeah, thank you. Really good question. In theory, no, they should not be linked, because the exit criteria from the recovery support programme were set many, many months ago, and there were 15 conditions in effect, and we believe as a system, and have tested that with NHS Midlands, that we have met the criteria to exit the scheme. So in effect, the exam question that was set at the start, we believe we've answered. But I've said all along, and I think your question goes to this very point, it will be very difficult for any panel looking at the exit from the recovery support programme to ignore everything that's going on around them, to ignore the in-year operational financial position, and to ignore that new letter that's come out. I think we have had one question as a system since that letter came out that I think came from the people looking at the recovery support programme, and I think the gist of the question was, you are going to meet the request that we've made of you for the 22nd, and you are going to give us a plan that gives us what we anticipate receiving. One of those questions I think that my ICB colleagues would never say no to. So in theory, it shouldn't be linked. In practice, might be, but the very clear exit criteria that was set, we believe we have met, and therefore are awaiting positive news from the national team that yes, Lincolnshire has exited the recovery support programme, but absolutely now has a significant challenge to deliver the financial plans that are required of us, no different to any other system up and down the land. And on that basis, either everyone would be in the recovery support programme or nobody would be. Thank you.
Thanks, Andrew.
Thank you, Andrew. Thanks for the question, Ian. Murray.
Thanks, Andrew. Clearly, that to get to the position of the 15 million, given the significant gap currently between the potential risk and where they want us to land, or indeed where we said originally we would land, that do you envisage that that will have an impact on our trust's delivery plans, our financial plans, directly or indeed indirectly, with partners having to change and alter programs that feed into us? And if the answer is yes to either of those, how do you envisage the board being part of a conversation that signs that off before the 22nd of November?
Okay, thank you. A question in two parts. First part, yes. I think if you look at the gap that the system is projecting it will have, and therefore what do we need to try and close between now and the 22nd, or at least have plans to close, I think that gap is probably about 20 million that we need to be finding. So between now and year end, that's virtually £1 million a week, isn't it, to try and find. So that is undoubtedly going to have an impact on everyone's plans. The priorities were set out in the letter: financial balance, urgent and emergency care, then the urgent priority elective. So some work will be slowed down, some work may well be stopped, and the system is working through what things might have to be slowed down or stopped. We are looking at every bit of our work, people side, financial plans, business cases, productivity, elective work, the whole range, and a number of those will impact on the plans that we had got. I can't quantify that for you at the minute, but we're working on that. The other part of what we have to do is that the plans that are submitted do have to be signed off by boards by the 22nd. And what we're now working through, and I sent a note to Malcolm last night, is how do we do that? Clearly, the ICB need to be able to sign stuff off, but individual provider boards need to be signing stuff off as well. So between now and then, we've got to concoct something that's both elegant but practical to ensure that we as a board can sign off what we need to sign off, and our ICB colleagues can sign off the total plan, which will wrap up the group, LPFT and the ICB spend as well. So be ready for some contact from a number of us about how can we squeeze that in, either before a system meeting takes place or after a system meeting takes place. But either way, the submission on the 22nd will have to indicate board support from LCHS and from the other part of our group. Thank you.
Thank you, and thank you for your question, Murray, because it's something that's preoccupied me, and we will need to grapple with the elegant yet practical approach that Andrew just outlined. But it is really important for me that board has sight of this. This is not something we are going to delegate up to the ICB, because they have a different set of responsibilities to ours. As we've had from our patient story, and our awards, we've got direct responsibility to patients. So we need to be happy with whatever is being said to meet this requirement from NHS England for across the country. So, I'm on it in terms of making sure board have an opportunity to look at this and express views, and to make sure they're content with the direction of travel, because it will have implications for us. So thanks for that question, Murray. Karen.
Yeah, thank you, Murray. Thank you, Andrew. I was just going to add to Andrew's point, of course, in either slowing down, stopping, or adjusting some of the work streams that we've got in order to meet the ask of us, either as individual organisations, a group, and or a system. that brings risks associated with it, doesn't it? Both in terms of the financial risks, but also the quality and patient safety risks that may or may not be associated with any action that we take. So as medical directors and directors of nursing across the system, we're also really clear that we need to very quickly and, again, elegantly, as taking Andrew's words there, find a way of quality assessing anything that we choose to offer to boards. So we're, in fact, whilst I've been in this board meeting, my apologies, Chair, I've also been having an offline conversation with the DONs and the medical directors about how we might do that, thinking about how we did this through COVID so that we were fleet of foot with some of the decisions that we needed to make, but equally we were clear about the risks that we were holding as a board. Thank you, Malcolm. Thanks
for those observations, Karen. We understand the load that this is placed right across the trust, this request from NHS England, and I can understand why they want to get a picture, but as a board we stand supported, but we will exercise our responsibilities within this. Okay, are there any other questions, queries or comments for Andrew for his report and the attached feature focus? No, that's good. I see you still with us, Gail. Would you still rather I passed over the next item?
I would, if you, because okay. we're waiting for a phone call from a consultant, so I'd rather that you pass over if you don't mind. Thank you.
No, of course not. Okay, so we'll come back to 2A, which is the Quality and Risk Committee, but so move now to 2B, which is to receive the Emergency Preparedness annual report, and I think I'm turning to Julie for this.
Thank you very much, Chair. So you will know that this has been a piece of challenge and scrutiny work that started in the summer. The original submission by the organisation was in August of our evidence against the 58 core standards. We have now undergone the check-in challenge from both regional and the ICB team, and you will see that we've come out as partially compliant. We have 24 of the 58 standards that we are fully compliant on and 34 partially compliant. I think everybody acknowledged from the check-in challenge session, we went first across the system, so we were able to share our learning with other provider colleagues that, as you would expect in response to the Manchester bombing learning, the actual approach to EPR assurance is very different to what it was, and that feels assuring, I think, to all of us, that actually the level of assurance for having been done and being able to evidence from board to floor was a different challenge than previous years. So in fact, there's definite learning for us as a board around how we cite and we see EPRR specifically as a board conversation, so the financial allocation towards our business continuity going forward and other such issues. So I think, Chair, I will make sure that that is very clearly outlined going forward, so therefore we're able to evidence our board's line of sight around this area. Also, areas of other learning were training, job descriptions, individual CPD, training profiles, absolute clarity to every individual that we are clear about our need to respond. So I won't go through the report in detail. I'll take it absolutely as read. Happy to take questions, but therefore I am closing the loop for this year that we are partially compliant as an organisation, and we have very clear action plans in train in order to be able to move that position from 24 fully compliant standards to much closer than the 58. I think it's also worth clarifying There are some areas that there will be an expectation that no organisation will be able to be fully compliant on when you get into the detail of what needs to be able to be shared. And I did have that conversation with the regional challenge team around where we should all be sitting. And as a ICB, there are a whole suite of the standards that we will need to do differently as a system going forward, in order for us as an ICB to be able to be much more compliant than we are currently. So I'm happy to take questions, Chair.
Great, thank you for that update, Julie. I think it's fairly clear that there's work to be done, but we're on it, would be my summary. Questions or comments for Julie? Nobody's going to ask the question of who's the Ken Dodd fan. There's an exercise called Diddy Men and Tickle Sticks lurking in here. Karen, elevate it for me.
Yeah. So before you all get excited, I am going to ask that question. It was just to make the point to Julie that clearly you've taken us with colleagues regionally and across the ICB through a very stringent and robust process. So it's really good to see exactly where we are partially compliant and then areas where we've got to do that additional work to strengthen our position. So thank you, Julie, for taking us through that so that we've got a really clear picture.
Thanks, Karen. Ian.
Yeah, thanks from me as well, Julie. It's a really clear report. I wanted to pick up really on the point you made about board being cited and so on that. And whilst it's a clear report, it's also a bit uncomfortable as well, because we like to have 10 out of 10 on everything we do if possible, don't we? So I suppose my question was just on that theme of board being aware. What's the process here on in for board sort of overviewing this or having someone to do it for them?
So Ian, I've already taken action and responsibility for different update and site. So in our budget setting for next year, I'm very clear we will need clarity over the EPR allocation. Some of these areas we need to be much clearer about. Our training reviews going forward, we will need to be able to see that. So therefore, Ian, it's about us as executive directors clearly sort of flagging that, so therefore we can assure the wider system and our citizens that we will be able to access that level of detail, training or resource if needed in order to be able to respond in times of extremist. So I've got a direction of travel, Ian, for that clarity going forward, and I did make the point to our regional team, it's actually not long now from this learning, only in October, in order for us to be able to demonstrate that ready for data collection again in August. So it's through that window of time for us to be able to demonstrate clearly this conversation in detail again is another ability to show we've created the airspace within our public board, and we will continue to do that as we do in subcommittees of the board where we would have the detail.
Thank you.
Right, thanks, Ian, and I'll let Sam have the final word and then I'll wrap this one up. Sam.
Yeah, I just wanted to ask, when do we expect the work to make sure the risks are captured on our risk registers to complete? There's a reference to it being underway, but do we have a timescale for that one?
Yeah, Catherine and I have linked on the EPR work already, so I'll let her clarify around absolute timescales. But as you would expect, post check and challenge meeting, that conversation started.
Okay, great. Catherine, question to answer.
Yeah, of course, happy to come in on that. So work has commenced back in July with deputy directors across the trust. in terms of just aligning those in the similar way that we did for national fraud risks and locally, regionally identified fraud risks. So it was a good process that we applied to the trust there, and we are following that. So they should be seen on the risk register. Some will come through this month in November updates, as well as through to December. So they'll be in by the end of this calendar year.
Great, thank you for that answer, and thank you, Julie, for bringing this to us. I think we need to approve the annual report, noting that there'll be a further update. So looking around, I think we approve that. Everybody content? Good, great, thank you. Let's push on to the frailty strategy, Anne-Louise.
Thank you very much, Chair. I am delighted to be presenting the Lincolnshire 5-year frailty strategy to public board. There is included with the front sheet both a copy of the frailty strategy and the presentation supporting. I don't intend to share my PowerPoint presentation. I will just talk through the sequence of slides if that's okay. So what is frailty? Well, for a very long time, we work with the premise of I know it when I see it in the health service without being able to quite articulate what it is from a clinical perspective. Whereas now we have a proper definition, and actually clinical research has been undertaken both to create a validated scale of risk assessing and scoring frailty, and actually clinical evidence supporting interventions which benefit this segment of our population. And really what it is a combination of the physiological changes in ageing in combination with somebody's long-term conditions that they're living with, leave them with a reduced capacity and reserve to deal with what would be a minor stressor for somebody living without frailty. And why this is important, because that can mean somebody dips below a line of managing independently or with their existing support package into not being able to manage as a consequence of a minor stressor such as a minor infection or illness or a fall, or it can be something non-physical such as a bereavement or a change in carer situation or a change of environment. And it can just make somebody change enough that they are predisposed to having an adverse event such as a fall. And our reactive healthcare system is set up, we respond to the fall, but we don't respond to the reasons why. So a patient, it is important because these individuals can end up in an accident and emergency department, and actually the minor stressor event has finished, but we're looking for the accident and emergency, leading us to over-medicalising this group of patients and taking them out of their own home. So public health data and the population health management team have shown that we have, in the population of over 65, around 23%, which is 85,000 people, are living with frailty, and of those about 10,000 are severely frail. And the PHM data on per capita spending per year shows that's around just over £6,000, which if you scale up is costing £61 million per year to the system of delivering this reactive model of care. By 2030, the spending for this population age group increases exponentially through Public Health England data. So I'm trying to articulate some of the case for changes that we are responding to the emergency and not identifying proactively people living with frailty and creating the holistic pathway for help for them that we need to. So in terms of how we could solve this problem, the journey so far in Lincolnshire is we've held a series of workshops with multiple stakeholders from health, social care, voluntary sector. We have heard stories from our staff of how they've experienced trying to care for frail older people in the system, and we've heard from people living with frailty as well. And we have created the strategy using the national evidence for what works. We've used the clinical care directorate in the system and the academic academy. It links beautifully to the urgent and emergency care recovery plan NHS England published this year, covers at least 5 of the 10 must-do actions. It links through to the system joint 5-year full priority plan around integrating community care. And the National GIRF team have visited us and rubber stamped the strategy also. So if I can move to the delivery model, there are 3 pillars within the delivery model that we are proposing. The first pillar is in primary care. The second pillar is around how, when that isn't enough, you access step-up services. And the third pillar is that integrated pathway, and that is wrapped around by proactive care and by an integrated workforce. So I'll take each of those in brief detail. So proactive care, the first workshop is coming up, and this is about ageing well, linking with third sector, linking with social prescribing, housing, health checks, and then we'll also move into identification of pre-frailty and how you can try to help progression or slow that down. The primary care pillar is around how we identify people in the community. Dr. Aubrey is leading on this pillar of work of how they use the electronic frailty index in primary care to identify people at risk and then stratify them using the clinical frailty scale. And that leads through care coordination. These individuals often end up with fragmented multiple episodes of care at the same time, which is really difficult to navigate. It leads to people not attending, it creates confusion and actually isn't patient-centred. So this is about holistically assessing the individuals, coordinating their care, creating strength-based personalised care plans and advanced care planning to support the person's wishes of how they wish to be looked after. When that isn't enough, it links into, we're calling it a single point of access, but the nomenclature may change. This is about, with good intention, we have multiple different services which are accessed in different ways with different referral criteria, but essentially are meeting the needs of the same group of patients. So we were proposing that we bring that into one and have a clinically navigated service that anybody, GP, ambulance crew with a patient can phone up and describe the need, and that way we can have, through trusted assessor and shared pathways, access into all parts of the integrated pathway rather than being a default position of the person has to go to the accident and emergency department. The third part is the integrated pathways that this service would link into. So the strategy describes how we will have community hubs where we can offer enhanced care to people close to their homes to prevent long journeys into secondary care where it is safe and provides a better experience for them. So even if the outcome is somebody does need hospital, that is still a managed part of the patient's pathway, then back out into these community hubs, which will be able to offer next day assessment, same day emergency care, diagnostics close to people's home. It links to some of the wonderful things Leo was talking about and point of care testing and using technology to monitor people and support them in their own homes. It links to the virtual wards, it links back into the community and end of life care planning. So that will be a fully integrated pathway that people access once, and the response is thank you, we will take it from here and make it happen. It is clearly very complicated how we will make that happen behind the scenes, but we have 4 community hospital hubs and also Grantham site alongside the 2 acute trusts. So actually we'll be able to create a large number of hubs close to people's home across the county. That's underpinned by an integrated workforce. So if we map all the services across the county delivering similar but different across all the providers, it's a bit like a ball of wool. There are multiple overlapping teams crossing the road, passing each other in their car in the road, going to the same patient. So we are proposing, and the workshops are starting, that we look at how we can share resources, how we can share tasks, how we can make it simpler for a person rather than having 5 different health and social care professionals coming into their own home each day, how we can share tasks to make that less intrusive for the person. We're also looking within that work stream about integrating our workforce with joint rotational posts and how we create a really vibrant career structure, for example, for our ACPs, our AHPs, and looking at our healthcare scientists and other professional groups coming together to create a really diverse workforce which have got a really excellent career pathway progression. So I think the next slide is, how will we know when we're getting it right? Well, there will be feedback from our patients, feedback from our staff and the experience of working in this way. They've told us it's frustrating now. Patient experience and quality outcomes, public health data will start informing us, and many of the non-elective KPIs that are already closely scrutinised will improve, because I believe if we get this right for frail older people, it will release capacity to get it right for other population groups as well, and we'll see that through the SANET and SEDIT data. We need to bear in mind we're also managing population growth, so this is one of the largest growing demographic groups. So I think I've given you a whistle-stop tour. I will be asked what the ask is, and I think it's perhaps a number of things. Is first, from a leadership perspective, that we support this ambitious 5-year strategy to transform how and join up how we're delivering care for frail older people. It is a significant cultural change programme, and that will be underpinned by things that we can do collaboratively, such as shared health records and how we progress working and supporting a joint workforce. I'm sure I've forgotten something, but it will come out in the questions, I'm sure, Chair. So I will pause at that point. Thank you.
Thanks, Anne-Louise. Can I just take Chair's privilege on this one? Because we have seen before a presentation about the shape of this, and as a board, we've been very enthusiastic and very supportive. I think I speak on behalf of board for that. The questions that spring to my mind, because this is the what, it's the when. And when are we going to see the plans, and where is that oversight of this going to sit? And I guess the fourth question will be, will we be able to do anything that will make a difference this winter? So I'm still at my enthusiastic impatience, but on behalf of the board, I think we are supportive, but when are we going to do this, and when are we going to see the concrete plans?
So what you've done is wonderfully what I predicted, that the single most important thing I forgot was to give you an assurance around some of the delivery of this, Chair. So I can come in and say, one of the things I was going to say is, why wait for Christmas? So whilst we've been following the process of creating the strategy and then rolling that out and socialising it with the leaders in Lincolnshire, we have also been working really hard to create the first pilot site for the community hub, and that we have done that through the Grantham ASR with the third ward conversations, and that in the first phase of that community hub is due to be opening in a couple of weeks, and that will offer ultimately shared assessment area where we can do diagnostics and treatments, as I articulated before, but also step up overnight care to function as a frailty assessment unit like the county has, can offer palliative, can offer reablement, can link to the stroke rehab pathway, but that clinical team also delivers the Grantham component of the frailty virtual ward, so we don't have handoffs, that people can step up and move down seamlessly through that pathway without there being referrals, without there being handoffs, without delays, in a very proactive pull model, getting people back into their own homes as soon as we can, Malcolm. So to give you an assurance that yes, a full worker plan is being developed, and the operational integrated pathway group started last week, but we've already been doing that. So we will take the learning from setting the Grantham and the phasing and scaling up of that across to the next site to be decided as a blueprint with the learning. We've already pursued workforce recruitment. We've recruited as well as having a nurse consultant as our integrated system frailty lead, we have another nurse consultant just be appointed within the system, which is fabulous. And we also have 14 training ACPs coming online. So clearly it'll have to be a phased strategy as we develop the workforce in the delivery of that strategy. But already doing it where we can.
Okay. And just sorry, I know Julie's waited to come in, but the so there's a plan in development, and where is the oversight going to be? I'm trying to think of how we play our role in the systems and in the trust to support this and get it going. I got told off for being too enthusiastic 4 or 5 months ago. What I want to see is the plan and the delivery and the investment to support you in the front line to deliver what is a very clear plan for how we improve this. And I still don't get a sense of who's sitting supporting with oversight and saying, great, this works, this doesn't. You know, it's the nuts and bolts of the oversight for me.
So on the leadership group, there are representations from all providers and social care and third sector arms. There is a structure of reporting into the ICB and to the Urgent Care Partnership Board, and I will bring back the formal plans as well as the clinical lead.
So it's the Urgent Care Partnership Board?
Yeah.
Okay, great. Thank you for that. That's what I wanted. I'll take them in order. Julie, sorry, I'll be keeping you waiting.
Thanks ever so much. And Louise, you know how incredibly committed I am to this agenda. The bit that I just wonder whether as a system we have been challenging enough to ourselves at is it's signed by yourself and Sadie, which is wonderful, but we know we can't really deliver an integrated frailty service without the local authority. So I suppose I am a bit curious as well, following on from our chair's challenge around where is the UEC board really the right place? I suppose for me, I worry about our local authority partners' front vision to this and commitment, because all of those service delivery actions only work well and you only really reduce the duplication when we think differently. You think of the live service, the heart service, the new mini jet, the new clinically led spa, all of those that we're so committed and passionate to deliver, but the duplication, the seamlessness impact for Mrs. Miggins is only really going to fall out as an alternative to ED when social care are signing it too with us. So I suppose I'm interested, if this is 5 years, is that as a board, do we need to say that actually in fact much sooner than that it's got to have local authority signed up to the front page too? I suppose maybe that's just as much a challenge to myself, but I think that we've got to be screaming about this a bit.
If I can respond to that. So local authority have been part of its design, Julie. So we have Afsana has been close to it, and Andrea Kingdom is part of our working group, and I presented it to BLEP, and Martin was there as well as Karen. So the second time in less than a week she's heard me talk about this. So they are sighted on it and very, very keen to link in with the proactive, but also this is an opportunity. Carers are often the people who know the person the best when they're starting to change, and at the moment they don't have many options of escalation, so they're really keen to work with us on that, Julie. So they're absolutely fundamental to it and have been part of it.
Thanks, Anne-Louise. Karen.
Yeah, I was just linking, so thank you, Anne-Louise, and yeah, it's just the second time I've heard it, but again, picked up other things as well from the first time where you presented it at BLET last week. I guess just picking up Andrew's point in his chief exec's update earlier on in the board meeting, talking about UEC and the risk that our population you could argue are holding when they're calling for an ambulance, and the risk then that EMAS have, and our part that we play as a group, but also as a community provider around decompressing our emergency departments. Of course, the frailty service and this frailty strategy and what comes from that is going to be really important to that. So as part of the oversight that I have leading our gold response and strategic response as a group and with system partners around the UEC agenda, we've been looking at hospital admission avoidance, of which the frailty service is going to be really crucial to. So in part, Chair, I think I'm offering, there's a link directly in existence through a process that we've got in place now for this strategy. And equally, the operational delivery of it has been overseen through our chief operating officers. So I think clinically, Anne-Louise and Sadie, who have kind of spearheaded the development of this strategy, we're already starting to see how we can pull that through into indirectly the UEC and decompressing EDs, and therefore managing the risk across the Lincolnshire system. I guess, Anne-Louise, what we'll need to work up outside of this board conversation is how we get some momentum into that, both in terms of enacting some of the really quick things that sit within this strategy. And I think you've already mentioned in part how we also drive the frailty virtual ward usage and occupancy as well, because I think all of those three things are really important in driving this strategy.
Absolutely.
So I hope that helps answer in part, Malcolm, the question that you posed, of one about oversight and two about where we're starting to see some traction. Thank you.
Thanks, Karen. It does, but I still think there's a system discussion we need to have about how we oversee the delivery of a number of programmes, not just because we're having the debate in the Farrer review, and this is another crucial strategic development, cross-trust, cross-system, that needs good oversight, good driving. And that's not a criticism of anything so far. It's just that if we want to support it properly, if we want to bolster it, to use the word from earlier, then that's what we need to do. Murray. Sorry, I'll bring you in at the end, Anne-Louise. Murray.
Malcolm, I absolutely agree with your point, and that's not to take away from this strategy at all. This is a great piece of work, and it's really important it's come at system level because it speaks to us all. But 2 weeks ago, I was at the System Dementia Strategy 5-year launch. We've got the Farrer 5-year or 3-year. We've got a number of things. So I think I'm in your space, Malcolm, in that we have heard earlier today from our chief executive that there is likely to be less resources in our system going forward. Therefore, as a board, we are likely to be faced with making some choices around how we as a board and a group support each of these system strategies, what the ask is of us, how we are able to respond, and with what resources in what timescale. That strikes me as a board discussion that we haven't had yet. And it's not to decry any individual strategy, but if we simply take each one and say, yes, we want that, which of course we do, that's not the difficult question. The difficult question will be, but we haven't got enough resource to do all of these things. So where do we decide the priorities lie? And I'm not sure I've had that conversation in this space yet. This is a new strategy, obviously, but there are a number of new strategies. So I would like us to get to a place where we're able to overview the whole in terms of governance and say, how do we allocate this appropriately for the people of Lincolnshire? And that's absolutely not to say this isn't the right thing to do, but I am very aware of the number of competing right things to do at the moment.
Yeah, great. I think we share the concern there, Murray. But I think there is you're absolutely right. Board needs to have a view on this, but I think the real solution for this is that the system needs to get a better way of viewing all these key strategic priorities to allow us to react to interact and understand our part in it. I think if we pull it apart too much and just look at it from individual boards' perspectives as a starting point, I think we'll end up reproducing some of the weaknesses in the delivery that we've had before. So I think there's a challenge there for us. I think Anne-Louise, is there anything else you want to say before we finish?
Only that it's going to LLG and some of that conversation might take place that Murray has described. There is a lot of synergy with the other strategies, Marie, that a lot of the same people to make sure there is an alignment, because part of our starting point is we have too much duplication and overlap without integration. So you will notice the joint 5-year forward plan for the system describes integrating pathways, and this is one of the examples of us doing that. It is probably the most complicated one to start with, but if we get this, that's exactly the challenge that then makes it easier.
And I'll be at LLG, so there will definitely be some of that discussion. We definitely need to find in the same way that we need to support and create the right environment for innovation, we need to support and create the right environment for actual delivery on this, to get beyond these, beyond the words. Again, not a criticism of anybody at all, but actually delivering and making that difference, so that final slide that you added about how we will know we've made a difference, we're actually starting to tick off because we are making a difference, and that's our job as board leaders, to support you to deliver that. Great, excellent presentation, Anne-Louise. Really pleased with that. I think the note is to be supportive, and I think we are, unless somebody's going to throw something at me at the last minute. Okay, great. Through exceptionally bad chairing, we need to pick up the pace a bit. So I'm going to go back to Gail and do the quality and risk, and then I'm going to take a 10-minute break, if that's all right, if everybody can hold on till then. So Gail, as with all these papers, assume everybody's read everything. You're standing in for Jim in terms of updating on item 2A, quality and risk committee. So Gail, over to you.
I am, Malcolm, thank you. And just to say, I wouldn't normally do this, but because I am awaiting a call from a consultant on behalf of my mum, our real life goes on as well, doesn't it, every day? Just because we're board members doesn't mean it doesn't. She's waiting for a call from a consultant from another trust in a different region. So if it goes, I'll have to go. But Karen and I have had a little chat, and Karen's happy to take over from me if necessary. So thank you for that. I will assume that everybody's read it. Yes, I'm doing this on behalf of Jim. Jim suggested that I just picked out some highlights, so I hope that's okay with everybody, because it's a fairly substantial paper, lots of things going on in the Quality and Risk Committee. Some of the main things that I wanted to pick up was that there were some, we reviewed things like terms of reference, and found out that, for instance, we didn't have a chief operating officer on the in attendance list. So we thought that was pretty crucial, actually, to have Julie Frake-Harris there, and or any chief operating officer there, in fact. So that was changed. There were some things that we wanted to highlight in terms of risk. So in terms of the lymphedema service, lots and lots of work is going on in the lymphedema service. I think there was some a decrease in the score in a positive direction, and so that was people were very clear that there was a plan in place. It was starting to work. There's a great plan trajectory going forward, so that was a positive thing. I think the other thing was to say that we've been talking quite a lot about our overdue date exposition, so where we get all the statistics from and all our information from, and it's been a challenge, but in fact it's improved across all divisions through September, which means the quality of the data we get is that much better. So that was a really important thing. And a couple of the areas that were highlighted were that children and young people and specialist services and integrated urgent and emergency care, they had met their trajectory, and there was significant progress by community hospitals. So that was music to all our ears. So that was a positive thing. Probably also worth highlighting that something called the deteriorating patient and medical gases group, two separate things, were met as refresh groups in September, and lots of work is going on in those two areas in terms of the deteriorating patient, how best to manage deteriorating patients and to make their life as positive as possible, and the medical gases group, that's been re-established as those two groups. Probably also worth, and I think Jim wanted me to mention this, that the Safe Nursing Care tool which has got one of our acronyms, CNSST, was successfully implemented in the Sleaford Community Nursing Team. It's going to be rolled out throughout all community nursing teams throughout the next year. That was after a period of a bit of a trial where it worked really well. So I think that was again something worth highlighting. We went through the winter plan. Julie and her team had done an amazing, and others had done an amazing job of putting together the winter plan. That's there at Appendix 3 for people to read if they'd like to do. And there was a lot of assurance in place that for those plans in the 23-24 winter period. Obviously, that's always a very challenging time. We're not fully in it yet, but we shall see how that plan works in practice as we go through. The other thing, and again this is in the appendices to Appendix 4, important to be aware of, the quality account and what's called sequence reporting is behind trajectory with some work streams established. Well, work streams have been established and improvement plans have been established for each of the priority areas. So whilst it's behind trajectory, there's a very clear plan to deal with that. And I think Q&R felt confident that the plans that were being put in place, but wants to obviously be keep an eye on that and be will be reported back. And then finally, just to say that there was a really comprehensive operational report received, and that supported one of the main strategic objectives. It provided plenty of detail of delivery of personalised healthcare and how we make a difference to the outcomes for patients, and that was a really healthy discussion and very gratefully received. So I hope that's sufficient, but I will ask Karen if there's anything that she'd like to add that I've not covered in particularly.
Thank you, Gail. It was just to point out, and you can read in the highlight report, there are a number of points there around safeguarding. And as we've got a different level of leadership across safeguarding that's supported by ULHT, and we've added a level of resilience to the safeguarding teams, you can see there that there are a number of risks that we've identified and we are mitigating against. So Q&R does spend quite a bit of time looking particularly at those, particularly the ones associated with staff training around safeguarding. And then finally, the point that I would make around the Safer Staffing Tool, which is a national, newly developed community staffing tool that we've had the privilege of being one of the pilot areas for, that also coincides with the establishment stroke workforce reviews that I've been undertaking across our community nursing teams, which we're just pulling together. And I'll be briefing executive team on this week, and then a paper will come through both FPEC and Q&R associated with that particular workforce. Thank you, Chair. Thanks, Gail.
Thanks, Karen.
Thanks to Gail and Karen for presenting that. I mean, Q&R is one of our busiest and most important committees. They're all important before other chairs start having a go at me. What the report shows is that vast depth of activity and breadth. I mean, this report I read and reread because of the coverage. So I know there's nothing to refer to us, but are there any questions or queries for Gail or for Karen from other board members? Right. Okay. I hope I haven't stunned you all into silence. That's great. Then we are to note this report, and we're really grateful for the work that goes on within Q&R. So thank you, and thanks again for presenting it, Gail, because I know you're picking up quite a lot today from various people who aren't able to do things. So thank you.
I'll take your thanks back to Jim too. Thank you. Yeah.
Great. Thank you. Okay, so I'm going to propose we take a break now. It's 11:42 on my little clock. So if we could be back by sort of 11:52, that would be really good. And then we'll try and move through the remainder of the agenda in the available time. So 10 minutes to stretch legs, cup of tea. See you back later. Thank you very much indeed. Okay, thank you and welcome back. It's 11:52, so I'll begin. I hope you had a chance to stretch your legs and get whatever brew is your favourite. I hope board members will forgive me for trying to pick up the pace a bit in this second portion of the meeting. I would like to try and hold us to time. We've had some really interesting discussions, and we've got more to come. Okay, so let's move into part 3 of the agenda. So item 3A, which is to receive a review of the annual public meeting. Catherine, what is there to say on this?
Thanks, Chair. I'll just note a couple of areas. So I'll take the report as read. So just to highlight, the Trust held, LCHS held our virtual annual public meeting to present our annual report and accounts for 2022-23 on the 19th of September, to formally and publicly note them and invite questions from patients and the public on those. The event was opened by yourself, Malcolm Birch, and presentations from our Group Chief Executive, Deputy Chief Executive and Director of Nursing, Medical Director, Chief Operating Officer and Director of Finance and Business Intelligence, to note various celebrations, innovations through the year, and that changes to the Trust Board through the year as well as reaching a break-even financial position. And celebration of the clinical strategy that was launched, frailty virtual wards and a number of other virtual wards and the hubs, integrated care hubs. In terms of numbers, as noted in the report, we had 79 attendees join the virtual live event on the day and 29 views post the event. And a range of folk joined us, a number of staff, representatives from LCHS England, Healthwatch, Lincoln University, Lincolnshire Police and the District Council as well, as noted in the report. So an interesting shift, I think, for us that more people joined us live this year as opposed to watching on demand than in previous years. So just helpful to note that. We also received 3 questions in advance from members of the public that related to recruitment and retention, drop-in digital sessions in Sleaford and the group model and how the group model would improve services for patients, and whether there was a merger planned for LCHS and ULHT, all of which the answers were recorded and available to view. The whole session on our website, the recording of the annual public meeting, and full responses to those questions are noted in the paper that's published on our website in our board papers. So if I can ask board members to note the report and information provided and support the ongoing collaboration of patient stories, such as the one that we opened board with today, to celebrate and improve provision of the annual report for next year as well. And obviously in our current position and working closely with United Lincolnshire Hospitals Trust, we are proposing that we look at a group APM annual public meeting for next year. Obviously, that will be to be determined. Thank you, Chair.
Okay, thank you. I think we note that. Okay, thank you very much, Catherine. Let's move on to section 4 of the agenda, the staff survey results. And do I need to make an apology? Claire, is this your first board?
It is, Chair, yes.
I'm really sorry that I didn't welcome you right at the start. You are very welcome.
Thank you.
And as our new people person. So you're going to kick us off, I suspect, on this staff survey results. Thank you, Claire.
Yes, thank you, Chair. I'll take the papers as read, but would just like to pull out some highlights, if I may. Q2 does show some improvement in progression against Q1 results, and our response rate has actually increased by 2% to 34%. All but one question has remained at the same level or has improved, with only a marginal decrease under the strained relationship questions. However, Chair, just to confirm, overall positive results, which place LCHS very much in the upper quartile in terms of the outputs of those responses that have been received. So happy to take any questions, but I'm assured that it's a very good response rate for a quarterly pulse survey, and the results remain consistently good in terms of those outputs received from our staff, Chair. Thank you.
Great, thank you, Claire. That's excellent. Sam, question.
Thank you, Chair. Thank you, Claire. Yeah, I just wanted to pick up on that relationships are strained at work question. The score is getting very close to crossing the 50% mark this quarter, just above still. but that would feel like quite a watershed. So I don't know if you wanted to make some additional observations about that. Obviously, well aware there are a lot of pressures staff are under at present, but relationships really are very important.
Yes, absolutely, Sam, and thank you for your question. I think it's multifaceted in terms of the work that we're doing, in terms of supporting our leaders, in terms of having the skill set to have difficult conversations, but also to support the staff, but also working with Fiona as our Freedom to Speak Up guardian. If there are further trends that come through the Freedom to Speak Up, which is the next agenda item, in terms of what other areas of work do we need to concentrate on. I think it is testament to the staff in terms of, they're working in really difficult circumstances at the moment, and that resilience and behaviours we do see slip as things become more stressful for our staff. So I think it's a case of ensuring our managers have the right support to have the skill set to support the staff, but also that staff do feel able to speak up if they're not getting the support that they need. So in some respects, Sam, it's good that it's coming through because it's highlighting that there needs to be more work, but also that staff do feel able to raise concerns, which is what we need to do in terms of being able to tackle some of these issues. So further work, I think, Sam, fair to say, but we are very closely watching it. Thank you.
Thanks for that question, Sam. It was one I was concerned about, and in an overall good survey, it's one that it's like all these things. You can't take your eye off the ball. You have to work at this because it's about the sort of trust we are, and of course, as we enter into a group, people will be starting to think, well, how is this going to affect us? And I think all these things are beginning to come through in some of this survey. And I was don't take this the wrong way, please. In some ways, I was surprised it held up so well, given the amount of uncertainty we've had over the last few months. But as a board, both executive and non-executive, and all the leaders in the organisation, we really need to keep working at this. Although Claire brings it to us as our Director of People, actually, it's all our jobs, this one, as we navigate this period of change and uncertainty in quite a challenging environment for the NHS anyway. But okay, any other questions or queries for Claire? Excellent debut, if I may say. It's equivalent of scoring on you, scoring as you come on in your first game for United. Sorry for those that don't like United. Okay, great. Thank you, Claire. Okay, so we're then moving on to 4B, Information Government Statement of Compliance. I suspect this will be Catherine again, will it?
It's me, actually, Chair.
My apologies, Julie.
So I am officially CSIRO's executive lead. So as we know, this is a submission timing issue. So in June, the submission for the toolkit was sent through, and our IG mandatory training hadn't been achieved due to the training cycle. I'd be pleased to report that when we resubmitted in line with the end of September timescale, our IG training was back at the 95% point. So therefore, this is to acknowledge the fact that we are fully compliant again as an organisation, Chair.
That's excellent, Julie. I know in this area how difficult it is to get to that 100%. And in any performance culture, setting anything at 100% is often a setting yourself up to not succeed. But actually, we've got a good record on information governance. So I'm really pleased with this one that we've managed to get this over the line up to 100%. So thank you, CSIRO, for overseeing that. But I know, again, right through the organisation, there'll be a phenomenal amount of work to get this up to date. So thank you. Any other comments or questions on that one? I look quickly across the board. No, thank you. Excellent. So let's move on to our item 4C, which is our Freedom to Speak Up report. And I think Fiona is joining us. Are you introducing this, Claire? Morning, Fiona. Are you introducing it, Claire, or are you going straight to Fiona?
Yes, if I could, please, Chair. Thank you so much. And Thank you, first of all, for everybody making me feel so welcome, and Fiona, thank you for all your work that you do. I think it's really important that the board are updated on the key themes that Fiona is going to share with you today in terms of Q1, Q2. So Fiona, over to you. Thank you.
Yeah, morning everybody. I'm here to present the Freedom to Speak Up Guardian report for Q1 and Q2 2023, and I'll take the report as read, but there are some issues that obviously I'll just highlight that I think a bit of extra clarity might assist. The Speak Up policy has been ratified. It's gone through JCNC policy group and should be live in January, and we will be monitored on that by NHSE, and it does align us then with our system partners as well. So it's a nice policy. I've just taken the pictures out. I'm continuing, and I'm probably making more site visits than I have done over Q1 and Q2, and I think there's a real sea change in that. In that, when I'm going around, people are stopping me. People are really, really keen to share, good and bad, and there is a real openness now to be heard from all levels. So I think initially in the first year or so, people will just look a bit at who is this person, but there's a real embedding of it now. And so they understand it as being a route to the senior leadership team. I mean, CEOs will say, what are our people saying? And it's usually a pretty unedited, candid version of what people are saying. And I appreciate that the senior team take that in the spirit it's intended of let's all improve and work through this together. So yeah, it's been seen as a very good channel, and I'm also challenging some of those intermediate leaders to make sure that they want to hear, and that's working really positively. We've had some real successes that I'll go on to talk about. Figures are static again. That's the third year in a row that we seem to be getting about 40s, 90 per annum. And themes of contact, no change again. Staff experience being the main one, but there's just a couple of bobbed up in the allyship, as people are ringing for other people now, and I find that really positive. Puts me in a difficult position as whether to hand out, reach out to those people, but I can arrange listening events if people have come to me via the ally route, and they've been, I will talk about that a little bit when I talk about healthcare support workers. I've also had 7 contacts from managers requesting advice and support on how to approach things and how to improve with their teams. I think that's a very, very good sign that we've got some real green shoots appearing. So if you look at the staff roles, you'll notice that we've had 13 from healthcare support workers, and that's where I was saying about the allyship. And if the service, you look at the service area breakdown, the outpatient departments and the inpatient wards were where the majority of these contacts came from the nursing and healthcare support workers. There were only 2 contacts from the community nursing teams, which is quite unusual. And I did do some sense checking there to see what's actually going on. Always a fear when there's low reporting, in case people are worried about speaking up, or they feel that apathy that nothing will be done. I will say, when I went out to these teams, they were, I mean, there's been a slight difference over these next Q3. Well, there's been a big difference, but this was very much about our reporting system, and the Opal made staff feel safer, that the risk was being carried by the organisation and they weren't worrying about it themselves in the evenings, or they felt that there was an overriding responsibility being taken to keep them safe, and that was, and obviously the patient safe. And I will also say that there was exceptional support from the CTLs. The clinical team leads in those community nursing teams are seen as real staff advocates, and that's lovely to hear. They're embedded in the team, they work alongside the team, and they navigate a lot of the concerns. Those, you know, there's just super staff, and we're very, very lucky to have those members of staff. Of the staff experience, only one actually cited bullying and harassment in their narrative. And I'll just talk very quickly about the healthcare support workers being given a voice to express how they felt. And that was I'd say a large piece of work that was undertaken in inpatient wards, listening to our healthcare support workers, and that came through the allyship route of somebody that had been spoken up, that had said, I'll link you with a guardian. And the stories were really powerful, and I think it came as quite a jolt to the leaders to understand that they've got this workforce that needed to be heard, and that provides such exceptional rays of sunshine to those patients. I mean, they're the eyes and ears, and it was so I've been back to that area. They felt really listened to. I've also talked to the leaders about when you're there, yes, they say the pleasantries, but are we actually saying anything to tell me, anything to grumble about? And it's sort of breaking down that loyalty, or I don't want to talk above, so, you know, the layers of the tiers of command that we've got in the organisation. And it was very humbling to meet these people and say, actually, they say thank you. I say, well, no, thank you. You've really been, you shouldn't have to be brave, but it was a big step for them to come forward and speak up. And I think we've really appreciated it, and we've really worked with them. The last thing you wanted to talk about was the patient safety issues. And I am a little bit concerned. We flagged the patient safety issues really quickly, but we're not feeding back to the contacts quickly enough. And I'm constantly chasing that. And that's a concern for me, because I can't, you know, make it right. I can't give the feedback, but I am chasing that. And so we've got one still outstanding, one person that's contacted me about patient safety, and that is booked in for Thursday, and they want me to sit with them through that. So we've got to get much smarter and follow up the contacts with the right sort of message, the thanks, and the feedback on what they've raised. I'm still logging protected characteristics, and 6 of the 43 contacts were identified as having protected characteristics, and that's 13.9%. I did that on my phone, so not great at maths. So yeah, and it was 12 last year, so standard again. So I'm hoping that's been interesting and beneficial for you, and I'm happy to take any questions.
Great, thanks, Fiona. The freedom to speak up guardian is a crucial part of our armory, if that's not too militaristic term, in terms of how we support our staff to be everything they need to be, through surveys, through our management structures. FTSIG is really important. As ever, a really comprehensive report. I note the concern around pace in getting back around patient safety quality issues, but again, I'm reassured that we're on it and we spotted it. But Sam.
Not a question, just a comment, just to welcome seeing those patient safety issues being raised through the FTSIG channel. We have been concerned at points in the past that not enough patient safety stuff was coming through that route. So very welcome to see that it now is. Well done.
Mm.
Yes, thanks for that, Sam. That's my experience from talking to other chairs is that FTSIG has a risk of becoming, you know, more bureaucratic than really the core of patient safety. So really great observation. Andrew.
Yeah, thanks, Chair. Thanks, Fiona. And relatively new back in the trust, but you're clearly doing a grand job on freedom to speak up. So thank you for everything that you're doing. You have mentioned in the report the sort of Lucy Letby case, and I think when NHS England contacted trusts, there were sort of 2 messages in it for me. One was about people feeling safe to speak up, and the second was then about making sure that when they do speak up, there's a response given quickly. And I think I heard you say in one case, we've got more work to do on that one. But my sort of interest is always about how safe and comfortable people feel speaking up through the normal management route versus having to go down a freedom to speak up guardian route. And I think I heard you say people like the CTLs are very responsive and are approachable, but it'd just be interesting to get your take about the general sort of mood of the place, because I've always thought in an ideal world you wouldn't need a freedom to speak up route if you had a truly responsive listening leadership team, that would be the normal route in which you raise issues. But clearly the NHS doesn't have that as yet. So your take on our approachability and responsiveness as leaders to people's concerns, please. Thank you.
Well, the contacts that have come to me through this are probably not being managed by somebody within their own discipline. So that's my observation, Andrew. And so they raise it and it's not seen in the same light, clinical light. I mean, that's interesting for us all to hear, isn't it? And then push back and then come to me. So that's, but then we're only talking 3. So that's my analysis of those 3 cases. And I think if you want hand on heart, I think that is probably what's gone on. There is a bit of misinterpretation of what other people's priorities are, which is a concern.
That's helpful, thank you.
Great, thanks for that, Fiona. Ian.
Thanks, and thanks for the report, Fiona. I thought it was really helpful. I just got a specific really, and it was relating to those people who have left the organisation. If my maths is right, about 10% of your contacts in Q1, Q2 have ended up leaving the organisation. And I just wonder, have we got any intelligence on why that might be? Because I can think that might be a positive or maybe a negative issue having people leave.
There's a whole vast spectrum of why they're leaving, and I can't pull a theme out. Some it's about not getting the annual leave they wanted, some or it's a secondment, other people it's relationships, so that I can't really bring a theme out, Ian, I'm afraid, but it's a multitude, so of all different issues.
Yeah. The fact it's not a theme probably helps.
Yeah, and I assume FPIC are picking up the oversight of exit interviews and all that wider set of information around that. Claire, did you want to comment on that one?
Yes, please, Chair. I think there's further work to be done on this element, aligned to the exit questionnaires as well, to see if we can start seeing some trends emerging in terms of our retention and turnover. So I'll be picking it up with Fiona directly in terms of how we can support from a people directorate to try and glean some trend analysis in terms of our leavers from LCHS, Chair. Thank you.
Yeah, great. Thanks, Claire. Okay, great. Thank you very much. I think we're asked to accept this as assurance about us discharging our responsibilities. I think we're happy to do that, looking around. Thank you for your time today, Fiona. As ever, it's been really nice to see you and interesting to hear from you on this as well. Thank you very much.
Yeah.
Okay, moving to section 5 of the agenda. So actually, I've just name checked FPIC. So now we're going to the chair of FPIC for reports upward from FPIC. Murray.
Thank you, Chair. So this is our report for my September and October meetings, which from hopefully you've seen from minutes actually managed to cover our full remit of financial performance, digital estates, health and safety, and strategic innovation. And in terms of high-level assurance, we continue to report 5 green areas in workforce and system collaboration, with 3 amber areas, mostly being around financial long-term sustainability, and there are no areas of red assurance. We've talked earlier today about the financial performance and from the reporting that we received up until Andrew spoke earlier today. I was going to talk about the positive moves in our financial performance and the move from hopefully from NOF4. But I think it is important that we reflect that we have made significant strides this year which does put us in a stronger position than we would have been in other years to address the challenge that NHS has set for us. One area that we do want to highlight, however, is that our capital spend has fallen behind plan, and the committee have asked to do a deep dive into this at our next meeting in order that we can better understand our sources of assurance around forecasting. The committee specifically wished to comment and to thank staff on the work that they had done to find recurrent saving to mitigate the financial impact of the board's decision to change strategic plan around staff bank. We've received 2 audit reports from our audit colleagues at Audit Committee. The first on staff retention provided significant assurance. The second on the better payment code identified a number of areas for improvement, and the committee's agreed an action plan which we will monitor on behalf of board. Finally, you'll note from the minutes that we were not quorate at our last meeting, and therefore 2 issues arise. First, we ask board to approve the decisions taken at that meeting, and secondly, in line with our colleagues on quality, we'd ask that you approve the revision to our terms of reference to include the Chief Operating Officer as a member of our committee. Thank you, Chair.
Excellent. Tempting though it is not to approve that, I think I better. Oh, Julie's putting a thumbs up, so we must approve it. Great. Okay. Comments or questions for Murray? Again, exceptionally good report. Disappointed that we weren't being able to be quorate, but we're working on that. So those bits which aren't captured in the recommendations, but you've just outlined there verbally, I think we're happy to support and approve those two items. I think everyone on board is nodding. Great, good. Thank you very much, Murray. Thank you for that update. Moving on to 5B, to the Audit Committee. Ian.
Thank you, Chair. Yeah, I think I'll assume that the paper has been read. I think it's fair to say that quite a bit of it is business as usual. It's probably not the busiest period for the Audit Committee, but nevertheless, if I can raise perhaps just a few of the points that are mentioned in the report. First of all, in terms of internal audit, we've got a new provider, and as we've just heard from the chair of FIC, they've already completed one particular audit. The reason for mentioning TIA is that they've got quite a lot of work to do between now and the year end to get us into a position where we can rely on them to provide a head of internal audit opinion for the final accounts process. They did confirm to me during the meeting that they're confident they can hit that position, so that is good, but it does of course put pressure on our people within the organisation as auditees to deliver on this, so we'll keep a close eye on that. External audits also attended the meeting, and in terms of their planning, I think it's fair to say that that is all on course for the year end. They've got no particular concerns about us as an organisation. They were asked about the effect of the group model and said that they would take that into account, but didn't seem overly concerned that that would be a major issue for their work. On that group model point as well, you'll see within the report that we will, as an audit committee, try and keep our eye on developments with the group model to make sure that our governance arrangements are as strong as they need to be. And then the final point, which is probably worth pulling out, is that you'll see that there was an update from the recently introduced Lincolnshire Audit Chairs Group, which sounds very, very grand. But there are only 3 of us, and one of whom is also the audit chair of ULHT. So that helps with the group work, I think, as well. But in all seriousness, we have developed a set of terms of reference which should complement what we're trying to do across the system without putting us into a straitjacket that doesn't take the key points for LCHS. So we'll keep that under review, and hopefully that will help things along. So in terms of the board's work, I think that I'm just asking you to note the report, and obviously if you've got any questions, then I'm happy to try and take them. Thank you.
Great, thank you very much. I'm sure it is a very grand group. You will sit around in top hats and frock coats. Okay, so any comments or questions for Ian on that one? We happy to note? I think we're all happy to note. Great, thank you very much, Ian.
Thank you.
Okay, so let's move on to item 7, which is the report on the integrated performance report, which has been looked at FPIC and at Q&R. Oh, am I turning to you on this one, Sam, to introduce? There's no name on this one.
Yeah, that's guilty as charged. Malcolm.
Okay.
So we've got the integrated performance report covering performance up until the end of September. As you've mentioned already, the constituent parts of this have been reviewed by either the Quality and Risk Committee or the FPIC Committee, and we've already received their reports. I just draw board's attention to the fact that segmentation of the waiting list by both deprivation and ethnicity has been added to the pack at FPIC's request. We've got 4 indicators not statistically capable of achieving their targets without redesign. Those are set out in the report, and there's information about what we are doing about that. We've also got 4 indicators showing special cause deterioration at present, and explanation of the reasons for that is provided in the report. I'm very pleased to report that we got 10 measures showing special cause improvement this month, which is an indication of the strength of our continuous improvement culture. Happy to take any questions or comments.
Thanks, Sam. And I know the strength of scrutiny and challenge conducted by both committees, but also by the executive team in some of these with deteriorated weights are ones that are right at the heart of work that we're currently doing. Things like UTC weights and delays in referral to treatment. So not having a discussion about those here at board does not mean they're not being really aggressively prosecuted to try and improve the performance. So are there any queries or questions on this report? Because I think we're just asked to note it here at board, are we not? Yes, we are. Okay, great. Okay, thank you very much. Thank you for your help in moving us on. That's great. So this is the risk assurance report, section 8 of the agenda. So we're turning to Catherine, I think.
Thanks, Chair. I'll be brief because the risk assurance report has been through committees, as noted in the upper reports already received and discussed. So 70 current risks open for the trust, and 4 of which had quite a bit of movement in October. So 2 had decreases in score, 1 increase in score, and 1 new risk, all 4 of which are under quality and risk remit and were discussed as per the upward report. The only other item I wanted to note is the work continues around risk tolerance to align all of the trust risks against the board advised ranges, tolerance ranges earlier in the year. So that continues. And obviously there's the item we talked about earlier, and that board received in September around the alignment of emergency planning and preparedness risks being aligned to our corporate risk registers. Happy to take any questions. Thanks.
Any questions or queries for Catherine on that? It very much reflects one of the things I like about our approach to risk is that for me, it does feel like it reflects what's happening. You know, one I've been particularly interested in is the lymphedema service capacity. So there's a bit of a reducing score there, but we've still got a long way to go to deliver the service that we want. And the purpose of these tools for us at board is to make sure that we've got a full understanding of what's going on. So my confidence in that is high. So I'm grateful to you, Catherine, for your oversight of that, but also for everybody that plays a role in identifying, scoring, and managing these risks, more importantly. But anyway, listen, my sermonising. Any questions or queries? Okay, so I think we're asked again to note this one and approve the movement of risks that are already there. Yep, so I think we could do that. Catherine was about to tell me that, so that's good. You're managing the risk of your chair very well. Excellent. So great. So let's note that and approve the movement of risks as identified. Then I think we can move on. So I think this is still you, Catherine. So this is the board assurance framework, item 8B.
Yes, thank you, Chair. Again, the board will have already seen and seen the ratings, so the ask is to approve those. Just to highlight, as per the upward report from both committees, the RAG rating discussion for that took place to the executive team has been reviewed and discussed in both committees as well. So again, just for clarity, I will just highlight that so that the full board are cited and can hopefully support and approve this way forward. The proposal is that was reviewed by the executive team and supported by both committees is the criteria remains for each RAG rating. Board members have previously noted agreement as per the board strategy session in February this year, and the risk management strategy and subsequent discussions in July and September. So not to change the criteria for those ratings, and also where there is minimal change noted at the end of the financial year to the beginning of the new financial year, the RAG rating and assurance in March can be proposed to be carried forward until the next quarterly report is received by the respective committees. Although, as we'd expect, if there's significant change to any of the aims, objectives, or any of those parts of the strategic aims and objectives, then we'd expect only aspects of that RAG rating to be carried forward and committees to advise and propose ratings to board for that. The third item there is RAG ratings, the red RAG ratings to remain for the relevant aims and objectives for Q1, particularly relating to those under the Finance Performance, People and Improvement and Innovation Committee. Just with the explanatory text around those gaps in assurance and gaps in control, as supported by committees. So apologies, I know that was a bit prolonged, but thank you for your patience there.
That wasn't prolonged at all, Catherine. I know there's been an intensive debate around the board assurance ratings as we switch from one year to the next, with you know, people like me pontificating that, you know, a year is just an artificial thing and that we need to keep our eye on it. But it seems that we've come to quite an elegant and sensible solution reflecting the views of chairs and the relevant committees that seems to really work for me. So it was worth going through that, absolutely. Okay, so are there any questions or comments for Catherine in this observations? Again, I feel the board assurance framework is working for me. I hope I'm not deluding myself, but I think it's reflecting what's happening in the organisation for me. Okay, great. Just as a by the by, as we move towards a group model, it'll be interesting how we look at the risk registers and the board assurance frameworks and how they can continue to provide that to the group. Sorry, I hope I haven't ruined your day, Catherine, because obviously that's an awful lot of work that we'll be needing to do over the coming months. Okay, so let's approve the proposed framework and the updates that we've got here. Okay, thank you very much. I'm feeling a bit like a bullying head teacher now because you're all keeping so quiet, and I'm wondering, hope we're not missing anything, please. So we move on to 8C, which I think is you again, Catherine. Procedural documents, which we always look forward to.
I'm pleased to hear it, Chair. Again, committees have well, I'd like to thank committees and of course all our staff who do an incredible job on this. It's not the most exciting, I know, for people other than me to review policies and procedural documents, but we are making significant headway, particularly in the those documents that are so important to us and that we rely on it, anything that happens at 2 in the morning, for those standard operating procedures and our out of hours aspects. So there are a number of policies noted there for ratification for board, please. They are in the reading room, so hopefully everyone's had a chance to review those already. And I will just pause there because the report covers it all. I won't go into detail about all of them. Thank you.
Now there's a bold claim if ever I heard it. The report covers it all. I've just written that down. Let's see what questions we get. Gail.
It's not a question. I just thought I'd reassure you, Malcolm, that I feel very excited on this. I'm sure my non-exec colleagues feel the same. And on so just to reassure you that we're not asking any questions about it because we haven't got anything to say. We've already asked the questions before it's got to board. So I think that's just an important thing to emphasise. So thank you, Malcolm.
Thank you for that. Gail, it was just my imposter syndrome coming up again there, you see, thinking that I've managed to shut you all up by saying I wanted to move on quickly. Okay, so in relation to this, I think we're happy to agree all those changes in policies, sorry, not changes, revisions and updating. I think we're in a good place from when I reviewed the committee documents that we're in a very significantly different place than we were a couple of years ago in terms of our policy framework. So thank you again to you and your team, Catherine, on that one. So we will, I'm just flicking back, approve, ratify the policies, approve the extensions, and note the SOPs and guidance documents. So thank you very much, Catherine. Okay, which brings us towards the end of the agenda. There's okay, so we need to we do used to put a review on here. So how do we think we did today? Everybody's just smiling like they're just thinking, is it lunchtime? Gail.
Yeah, I am thinking, is it lunchtime? But I thought it was a good meeting. I thought there was some good discussion. Yeah, I thought good papers, as there have been for a number of occasions now. Lots of challenges, but we know that, don't we? So, and I think it's good that we're referring more and more to the group. So just to say that's coming through more and more, I think that's important. And particularly as this is a public meeting, I think it's essential that we do continue to do that more and more. So thanks, Malcolm. I hope that's helpful.
His patient story I thought was particularly helpful today, really illuminating both the individual case but also things where we need to take action, and the assurance items, the FTSUG, the risk register, the assurance framework are all really important and do provide that insurance, as do the reports from committees. But for me also the frailty presentation, again, it's very welcome. We know it's the right thing to do, and I think Anne-Louise, you took it in the spirit that it was offered. It was more sort of, okay, so where's the plans and how are we going to know we're going to get there? So I think as a board, that's exactly the sort of things we should be doing in terms of understanding where our organisation is, understanding the culture, supporting a positive culture, but also finding things to get on and make a difference. Great, so thank you all for your time this morning. I know you'll be disappointed, but I'm not joining you at private board this morning. Gail's stepping up and will be chairing this afternoon. So enjoy your lunch. You're back for private board later, and I'll see you all soon. Thank you very much.
Thanks, Malcolm.